So today I'm going to talk a little bit about some work that I've been doing recently. So this is kind of extra work that I've done beyond the risk modeling chapter of my PhD, just basically bringing, because it's taken me that long to get through my PhD, this is bringing some of that work up to date. And as part of a wider rollout of my PhD project to the rest of PQIP, and I'll talk a little bit about that as well. We wanted to just try and update and improve some of the risk adjustment modeling we've been doing. So I'll talk about the development and internal validation of a risk adjustment model for morbidity in a cohort of patients undergoing major elective colorectal surgery. So in terms of the sort of scale of the problem, there's around 1.5 million major surgical procedures that take place every year annually. And from the USOS study published in 2016, we know that around 25% of patients who undergo major surgery will suffer at least one complication postoperatively. So whereas mortality now is down at 1.5% or so for major elective surgery, morbidity and complications are still much higher than that. I think if we're looking for things to try and improve from a quality improvement perspective, then obviously having something that is common and is perhaps slightly easier to address complications and morbidity than it is mortality. I think that's a reasonable thing to go after. So one of the things I wanted to do with my PhD work was looking at how we can try and monitor and improve outcomes. The literature would suggest that if we're doing that, then the type of monitoring that we use should be continuous. So it's not kind of annualized assessments using funnel plots, etc. It should be continuous so that we can see trend over time, and that it should incorporate risk adjustment. And there are now kind of various methods that you can use to do this. So there's exponentially weighted moving average charts, which the ICNARC project uses, and NELA have also recently adopted. Risk adjusted cumulative sum charts, and then these things called VLADs, which is what I used in my PhD. So that's a variable life adjusted display. And if this works,
James, should there be audio with this?
yeah, is that not working?
Not for me.
Let me.
I mean, it's pretty self-explanatory.
Cool. I'll let it run and then I'll just kind of talk through it a little bit anyway. Hang on, let me. So basically that's a VLAD over time. So above 0 is fewer patients having complications than expected based on the risk adjustment models. Below 0, more patients than expected. And then basically upward trends over time, positive, downward trends over time, negative, to allow kind of earlier identification of positive trends. So you can try and learn from positive deviance and pick up poorer runs. So that you can intervene and do something about it sooner. And that's some of the theory behind the exponentially weighted moving average charts with NELA, is that sites were finding that if they were identified as an outlier when the report came out, but that's kind of 12 to 18 months after that data has been collected. And they didn't really get anything in that period to say, well, look, there's a risk you're going to be an outlier. Things look a bit worrying. What's going on here? So that's the kind of theory of, well, here's something you can look at with some risk adjustment to say, are things going well? Are things perhaps worrying? And then you can start to investigate some of that. So some of it will be data quality. Some of it will be processes. And I think there's within the NELA information that they released as part of the exponentially weighted moving average charts, there's kind of guides to investigating poor trends and positive trends. So in terms of risk adjustment from a morbidity point of view, there are a few options kind of out there off the shelf. So the POSSUM, the NSQIP model, and SORT morbidity model, which Danny and Matt worked on. But I think an important thing to note from a monitoring point of view, that calibration is particularly important, because models that underestimate risk will make outcomes appear better than they are. So trend over time will be positive, even if that's not necessarily the case. It can be purely statistical based on the model underestimating risk. And if it overestimates risk, it's going to make outcomes appear worse than they actually are over time. So that calibration is really important. These are just some calibration charts taken from the NELA paper on the right-hand side. And essentially what you want to see is that they just kind of hover up this 45-degree angle line, in that basically the estimated predicted risk on the x-axis is the same as the observed risk. So when you look at your spread of data in terms of calibration plots, you want to see that the dots, the points are nicely spread along that 45-degree line. So there are some issues with the off-the-shelf options. So POSSUM is probably the most widely used risk adjustment model that is out there, but it was first published now over 30 years ago. 1,300 patients undergoing general surgical procedures, but it was a mixture of emergency and elective procedures. And it has been demonstrated, this paper here from 2018, but numerous other papers, that it overestimates morbidity. I think that's probably a reflection of the fact that over the last 30 years, surgical practice has changed significantly. But it's whereas there have been the kind of PPOSSUM, colorectal POSSUM, vascular POSSUM updates of the mortality element, the morbidity element of the model has never been updated. The American College of Surgeons NSQIP risk calculator is a more recent one. It's a huge data set with millions and millions of patients. They have specialty specific models, and they also have procedure specific models as well now, because of the amount of data that they've been able to collect. But it has never been validated for use in a UK population. They haven't published the coefficient, so actually it's difficult to calculate an NSQIP risk for a large cohort of patients without going through and doing it manually in their calculator, which just isn't feasible for a kind of project like PQIP. And also many of the variables that are included in that model, and also the classification of those variables, are not necessarily how we collect data within the NHS. So it's not really one that you can just kind of pull and use. In terms of the SORT morbidity model, it was a single centre cohort of patients from UCH, so just over 1,500 patients, but it had a variety of surgical specialties, and just under half of those were orthopaedic. And just over 50% of patients had no documented comorbidity. So a different type of surgery, relatively lower risk cohort of patients than those patients undergoing surgery in PQIP, and it's not been externally validated. So given the title of the talk, it will come as no surprise that we decided to develop and internally validate a model using PQIP data. So our outcome measure was postoperative morbidity survey at postoperative day 7. This is a kind of 9-organ domain system with various criteria within each of the organ domains. We took this as a binary outcome, so morbidity present or not. So if any of these morbidities were present at within the 24 hours of postoperative day 7, then patients were defined to be POMS positive at that time point. So that was a positive outcome in terms of when we were analysing the data. That in itself as a composite outcome measure potentially brings problems in terms of modelling and model performance, but we can maybe talk about that later. This is how our cohort came together. So we exported patients in April of last year, and we decided to censor that up to the 31st of March 2020. The reason for that was to try and reduce the impact of COVID on the model development. Although there's an argument moving forward that COVID is going to be around, so perhaps we should in future maybe look at how we incorporate that into the modelling process as well. We excluded any patients with a missing outcome, which fortunately was only 49 patients. So the data completeness in this data set is great. So we started with just over 31,000 cases exported. When we that dropped to about 26,000 when we said only before the 31st of March 2020. And then when we looked specifically at colorectal surgery, that was 11,695. And then we included 11,646 in the modelling. So kind of no significant drop off when we looked at the kind of eligible population for this study, which is great. First step of any modelling is data cleaning. Now, kind of oversimplify things here because these are not the steps. There's a huge number of steps that go in, and actually data cleaning is probably the most important step of modelling and probably the most time consuming as well. So we decided to remove implausible values from a clinical perspective, but made those fairly wide. I decided not to censor or winsorize the values, basically because once we've removed values that were just not clinically plausible, actually the spread of data didn't seem too broad in terms of needing to winsorize. And if we had have winsorized at that point, then we'd have winsorized essentially to normal ranges for many of the continuous values. We combined categories with less than 0.5% of cases just to reduce the risk of overfitting of models. And then overall data completion was about 96% for predictor variables, so really good quality data. We used multiple imputation for missing data. Now, there's one particular variable that we felt warranted inclusion, which was a Rockwood Clinical Frailty Scale, but this was only added to the data set in January 2019, so had quite a big proportion of missing data. So 65% of cases were missing data for that. And we did a sensitivity analysis to look at the proportion of missing data and impact on variable coefficients after its introduction as one of the sensitivity analyses in the paper. So overall, we then had 31 variables for consideration of inclusion, and we deliberately excluded variables that could be seen as related to quality of care. So we wanted to only include variables that were non-modifiable at the point of admission for surgery, basically. So patient risk and procedural risk, but not things like interrupted blood loss, duration of surgery, etc., that kind of could be viewed as changing with quality of care. Now the continuous variables, so these are the 12 continuous variables that we had in the model, and often they're at least initially in the 31 variables that we had for consideration. And often their association with outcome isn't linear, often ends up being U-shaped or J-shaped curves, as you can see here. And they can be handled in different ways. So some people, like in the sort mortality model, will categorize those into groups, but I think you lose quite a bit of information if you do that. So some models like the Neela model will use quadratic or cubic transformations, but I opted to use restricted cubic splines, which are just slightly more complex from a mathematical point of view, but actually in R and other software packages are relatively straightforward to implement. So that basically it's places knots, so you can see these little vertical lines at the bottom of each plot. So that is where the knots are placed, and then the software package basically just fits fractional polynomials around these to create a nice smooth curve. And you can see for most of the variables, the lowest associated risk, which is the lowest part of each curve, is associated with values within the normal range, with then, as you'd almost expect really, outside of the normal range, risk increasing. So in terms of the multiple imputation procedure, basically what this does is takes your original data set with missing values, which for us was just over 11,500 patients, and then you end up with 10 different data sets, or however many you choose to impute, with different missing values replaced in each data set of imputation. So you end up with 10 data sets of just over 11,500 patients to then analyze. And because we were going to implement this prospectively for monitoring, we wanted to try and reduce the 31 potential variables that we had available, and we wanted to try and reduce the risk of overfitting because we're applying it prospectively. So we chose to use backwards variable selection to try and identify some of the stronger predictors of postoperative morbidity and come up with a more parsimonious model that was easier to implement in a software solution going forward. So to do that, we fitted a backwards stepwise model to each of the imputed data sets, and we drew 500 bootstrap samples of each data set. So in the end, we ended up fitting 5,000 models, and then we pooled the variable selection frequency across those 5,000 models to give us our final model. So variables that were selected into more than 70% of those 5,000 models, we then put into our final model. And the kind of the bootstrapping, which I'll mention again in a little bit because we used it for internal validation as well, essentially is sampling with replacements. So the easiest way I found to kind of try and explain it is that if you have a bag of Skittles and you draw a Skittle blind at random from that bag, find out what color it is, you then take a copy of that color. So if you pull a green one, you put a green one into your new pot and you put the green one back into your original pot. And then essentially you keep doing that however many times you choose to. So for me, I kept the sample size the same, so 11,646 times. So you then end up with what we had for this time was 500 new bags of Skittles, effectively, all made up of the first bag. But because you're drawing at random with replacement, some of those Skittles might appear 2 or 3 times in the new pots. Some of them might not appear at all. And effectively what you end up then doing is, the theory at least, is that this bag of Skittles, when you analyze for this part, the variable selected, or when you're doing internal validation, when you look at model performance in this model compared to in the original cohort of patients, the difference in performance here should reflect the difference in performance between your original sample of patients and the true population. So that's the kind of theory of bootstrapping, at least. So these were the variables that were selected, how frequently they were selected into those 5,000 models, and we set a cutoff based on previous literature of 70%. So we ended up with 12 variables in our model. So mode of surgery, so robotic, laparoscopic, open, clinical frailty scale, sex, severity of surgery, so it's kind of minor, intermediate, major as one group, and then X major and complex, ASA grade, BMI, sodium. We also included index of multiple deprivation, which is kind of a whole sort of separate talk in itself, really, of how we did that. And if anyone's particularly interested in that, we can maybe talk offline about it. Creatinine, age, white cell count, and urea. And these are the model's odds ratios, which might be a bit small for you to see, but interestingly, the clinical frailty scale showed, as frailty increased, as you might expect, that the risk of postoperative morbidity increased as well. So a decent association there with 95% confidence intervals for the odds ratio not crossing 1. I think we're one of the first models to include a measure of frailty as well, which is interesting. IMD as well. So Dermot's done some recent work looking at IMD, and Tom Poulton has as well, actually, within the NELA data set, looking at IMD in association with postoperative outcome. And actually the 2 most deprived quintiles were associated with increased risk of morbidity. And again, with 95% confidence intervals not crossing 0. And interesting for our model, the effect of age and increasing age was relatively limited compared to others. So you look at the odds ratio of being 18 and above, it was only 1.18 compared to 0.96 for being age 30. But I think some of that probably is explained by the inclusion of the frailty measure. And actually, once you adjust for other factors, age in itself as an individual variable may not necessarily be a strong predictor of outcome. So looking at model performance, we again used bootstrapping, and we used something termed the correction of optimism. Basically, model performance in your original data set will always be overestimated because the model variables are fit to your outcome. So this is a method, as I described before, where you can use samples drawn at random. You then fit a model to this new bootstrapped set of data. You then use that model and those coefficients to estimate risk in your original data set. And then you work out the difference in performance between when the model was fit over here and when you fit it back to this. And then essentially you can calculate the average of that. And then you subtract the average across all of these samples back from your original performance in your original data set. And that gives you the correction of optimism, essentially, which for our model, so the area that's looking at kind of C-statistical area under the curve. So for this, an area under the curve of 1 is perfect. So it's discrimination is the kind of ability of the model to differentiate between those at high risk of the outcome and those at low risk of an outcome. So 1 is kind of perfect separation. So it gives a high value to all of those patients who have the outcome and a very low value to all of those patients who don't have the outcome. Now, morbidity models in the literature are generally perform more poorly from a C-statistic point of view compared to mortality models, I think, because one, it's a more difficult outcome to predict. It's a softer outcome than mortality. And particularly with our models are looking at the POMs as an outcome measure, it's a composite outcome measure. And it's reasonable to kind of guess that if you're looking at the need for blood transfusion on day 7, the factors that feed into that might well vary from the risk of being on a ventilator at day 7 postoperatively. So that, I think, all in all makes morbidity slightly more difficult to predict. But our performance in terms of this area under the curve was 0.672, and then at internal validation performance was maintained to 0.66. And we also compared the performance of the POSSUM model in our data set, and we recalibrated POSSUM and SORT morbidity to our data sets. We freely estimated the model coefficients within our data. So our model outperformed the POSSUM model and the SORT morbidity model, I think, both in terms of C-statistic and also in terms of calibration curves as well. So here on the left-hand side is the PQIP model, and POSSUM in the middle and SORT morbidity on the right. So you can see that the PQIP model has a larger spread of points and is kind of closer to the 45-degree line that I mentioned earlier. And I mentioned before that the calibration for monitoring purposes is particularly important. So we kind of explored the calibration in a number of different ways, but essentially the calibration looks good. And I think despite the fact that the area under the curve is a little bit lower. So for that, 0.7 is kind of viewed as moderate discrimination and is ideal what you would like. And obviously 0.8 or 0.9 is better. But despite the fact it was a bit lower, given the good calibration in the model, we felt it was suitable to use for the purposes we were talking about. So this really is what it's all about. It's not necessarily the model itself, but it's what you kind of do with it. So this is what we are planning to implement through PQIP. So this is the dashboard and what it's going to look like. So we've combined some of the work that Matt has done looking at dreaming and associations with postoperative length of stay. So we have a kind of dreaming 5 process styles at the top with color coded according to performance. So looking at the number of patients that are drinking, eating and mobilizing on day 1, and then the constituent components, and then getting the IV drip down at day 1 within 24 hours of surgery as well. And then underneath, we've got some wider process measures around the timing of surgery. So looking at individualized preoperative risk assessment, looking at pain scores in recovery, avoiding NG tubes, avoiding abdominal drains, and then preoperative carbohydrate loading. And then in the middle is the VLAD that's going to hopefully show people if they're doing well, so they can learn from things, and if they're not doing well, they can pick things up earlier and implement change. And I'll just finish with this quote from George Box, who's an American statistician. He said, "All models are wrong," which I think is true. There are no perfect models out there, but I think some of them are useful. And the R code so we're hopefully in the next week or so submitting this work as a paper to the BJA, and all of the R code for the analysis is available at this link, which is on GitHub. So if anybody wants to have a look and nick bits of code, you're welcome. Hopefully there aren't any major errors in there. Thanks. If there's any questions, fire away.